So next is Perianal Sepsis V35, another high yield topic for exam. A 30-year-old male presents to A&E with this severe anal pain and tender perianal swelling. How will you manage him? I would like to take a history, duration of symptoms, onset, any bleeding per rectum, and if history of fever, previous surgery for perineal sepsis, and ask about diabetes and Crohn's disease. Examination is often limited by the pain. I would look for a well-defined painful lump or an area of induration. Lump, so there are buzzwords. I will look for lump. I will look for area of induration. The skin over the lump was necrotic, and any previous surgical scars. If this was the first presentation, I would book the patient for incision and drainage of the abscess. If there are a history of recurrent abscess or fistulas or suspicion of Crohn's disease, I will advise contrast enhanced MRI, that's gadolinium contrast MRI, to delineate the extent of sepsis and rule out horseshoe fistula. What would you do in theatre? A patient will be in lithotomy position. I would perform rectal examination and then rigid sigmoidoscopy to exclude malignancy and look for internal opening. It feels like a grain of sand. And if there are any suspicion about Crohn's disease or HIV, I would send tissue for pathology and microbiology. What you do next depends on your training. The current recommendation is that the index operation should deal with the abscess, incision and drainage, and do not use Vic. It's not going to help the patient, and fistulas are best delineated and defined in the absence of inflammation and decisions regarding definitive management. Cetone or fistulotomy can be made at follow-up examination under anesthesia. In my practice, I call the patient in clinic in 4 weeks time and examine him and then take things from there to ensure wound is healing. And if ongoing symptom, then suspicion of Crohn's, I will advise colonoscopy and MRI. And if ongoing symptom, no suspicion of Crohn's, EU and rectum plus Cetone. What is the microbiology of perineal sepsis? It's again very important viva question. So skin organisms or gut organisms. If skin organism, the abscess should not reoccur, and gut organism, it is likely that there is underlying fistula and the patient will get recurrent abscesses. What is Goodsall's rule? If the external opening is anterior to the transverse line, the track is directly to the internal opening in the anal canal. The track runs directly, and if the external opening is posterior to the transverse line, then the track curves backward to the posterior midline. How would you manage someone with a Crohn's disease? So in acute setting, I would order an MRI, delineate the nature of the sepsis, perform an incision drainage, and refer for gastroenterology for biological management. And sometime I will put the Cetone and aim of draining sepsis to allow the gastroenterologist to consider biologic therapy like infliximab and azathioprine. Patients may need a defunctioning stoma. To allow complex fistulas to heal. In some cases, resection of the diseased bowel will also improve fistulas. Thank you.